Right. Let's talk about coronary artery disease. Please pay attention to this. Okay. Nucleus will not ask you to define what coronary artery disease is. But what you need to know is that focus on the word coronary. Anytime you hear coronary, we are dealing with the heart. So arteries, these are the blood vessels that carries oxygenated blood through the heart. The disease, it means that there's a problem inside this artery. Usually, main problem we're going to be talking about is building up of cholesterol. There are so many other factors that can cause this coronary artery disease, but for the sake of the NCLEX, the most common cause we're going to focus on is the building up of lipids, which is called sclerosis. That happens, it will be very difficult for blood to move towards the heart. And so the demand of the blood, um, oxygenated blood, oxygen will not be able to be met. And that is what we call coronary artery disease. So let's look at what it is. The definition here, coronary artery disease is the narrowing or obstruction of one or more of the coronary arteries as a result of atherosclerosis, which I have already just defined as the building up of cholesterol in or lipid in blood vessels. In this case, I'm talking about the arteries, which is the accumulation of the lipid containing plaque in the arteries. The disease causes decreased perfusion. So our main problem, which I already talked about, is when we have a narrowing of the blood vessels, then we have less amount of blood going to side of the heart needs the blood. So we have a perfusion problem. As a result of that, the heart muscles begin to die, or myocardial tissues will not be getting enough oxygen, or we have inadequate myocardial oxygen supply, leading to either hypertension, angina, which I'm going to talk more about, dysrhythmias, which is abnormal electrical activities of the heart, and then we talk about MI, which is myocardial infarction. We'll be focusing more on our heart failure, and sometimes it leads to death if care is not taken. So, what is going to tell us, or how do we know if somebody has their coronary arteries being narrowed or there's an obstruction to the flow of the blood? First, when we have less oxygen going to any part of the body that is not getting enough, one of the signals is going to be pain. And in this case, the location of the heart is around the chest, so the pain will be around the chest, and therefore the person will be complaining of a chest pain. Next, since we have less blood going, the heart will begin to pump faster than normal, and therefore we have palpitations. Next, we'll talk about dyspnea. That's difficulty breathing. The respiratory system would like to compensate for what is going on. And again, we have difficulty breathing, which is dyspnea. Then syncope. This is the sudden loss of consciousness as a result of the low uh, blood flow, or when the heart there's a sudden change in blood pressure or the heart rate. Then we talk about cough or hemoptysis. Hemoptysis is when you are coughing out blood. And then we have excessive fatigue. Now, fatigue, this is where you get tired easily. And why? Because you have less energy now. Now, the heart is working more than it should be. And again, we don't have enough oxygen going on. From the beginning, I may mention that we need oxygen to be able to burn the glucose and then produce the energy. Now we have problems with getting enough energy, and therefore we have less production of energy, and so the person will be more fatigued. So with coronary artery disease, when we see these symptoms, this is going to be our assessment. Now, how would the question be framed when you are going for the test? It will fall under the physiological changes or physiological adaptation. So which of the following clinical manifestation are you expecting? with a person with diagnosis or with a person who has been diagnosed with CAD. Know that this person has a low amount of blood or oxygenated blood moving to the heart. So we're talking about chest pain, palpitation, dyspnea, syncope, coughing blood, and then also excessive fatigue. So then, what are some of the things that we can do to help this patient? This is a medicine intervention. First, you instruct the client regarding this is where we have the health promotion aspect. In this case, you have to teach the person to prevent it from happening in the first place. Where will they ask you this type of questions in the risk reduction? So in this case, you'll be teaching your patient that they have to be on low calories, low sodium, and low cholesterol diet. Then also they have to be on low fat diet because these are the main thing that will cause the problems. Then with increase, they have to also increase dietary fiber. You'll be asking David, come, you're talking about fiber here. When you are constipated, you'll be straining, and when you're straining, your oxygen demand goes up. Already we have problems with getting oxygen to the heart, and therefore we expect the person not to have constipation. So anything that you can do to decrease the demand of oxygen will be a good choice to take, especially when it comes to select all that apply. Stress is also number one leading cause of all this, the demand of oxygen. So again, make sure that you'll be having, you have less stress. Teach them things that will reduce their stress. If you are working in a stressful environment, change it. Then you have to learn to control your blood glucose. If the person is being diagnosed with diabetes, you need to make sure that the glucose levels are being controlled. If not, they risk getting myocardial CAD. Then increase activities and exercise. So exercise, we're not asking you to go to the gym every day. At least walking every day after work would help. Please do not confuse walking at work as an exercise. Yes, you're working, but you are also under stress. So it is always advisable that once you get out of work, you have, when you're not thinking about anything, you have about 5 to 10 minutes walk, and then with stress free. This will help control. This will help increase your oxygen, or it will help clear the blood vessels. I'm not going to focus on that area, but definitely think about its health promotions. These are things that you can do to prevent CAD from happening. So in the health promotion aspect, you'll be teaching your client all this intervention. That's where they will be asking you on. But this one, where we have the assessment, the person is already in trouble. So these are the things that they'll be complaining. And when you see these ones, this should tell you that the person is having CAD. Now, please pay attention to this because these ones, once you miss it, the other part is going to be more difficult for us to understand. Then let's come to medications. In terms of medications, when our blood vessels are narrowed, one of the ways to open them is give them the nitrates medications. In this case, we'll be talking about nitroglycerol. With nitroglycerin, it helps dilate the coronary arteries, and this will improve oxygenation or the flow of blood. We can also give calcium channel blockers. One of the things that the calcium channel blockers do is that they also dilate the blood vessels or the arteries, and therefore they can also help improve the flow of oxygen. Another one is that if the blood vessels are undergoing spasms, this one can also reduce or prevent the spasms from happening. And therefore, calcium channel blockers can help increase the flow of blood to the heart. Next, we talk about cholesterol. You give them cholesterol lowering medications, and this reduces the development of atherosclerotic plaque. Here we're talking about the statins. So Lipitor is the most common one, which I believe you have given it before. Then we have the beta blockers. The beta blockers, they are there to reduce the blood pressure and also to reduce mostly blood pressure. So those are the medications that we're going to be talking about. And like I said, I think we did talked about some of the nitrate earlier on last week. Anytime you see nitrate, think about the dilation of the blood vessels. And in this case, whenever you are going to give any of the nitrate, make sure that you check the blood pressure before you give it. If not, you might further drop the patient. And I gave you an example like Viagra or sildenafil. It's also another nitrogenous compound that is used for erectile dysfunction. And so if the person is on it, make sure that you ask before you give any of this nitrate. One of the things that I want you to remember is that with the nitrate, the most common side effect is going to be headache. So if you're giving somebody a nitrate, let them know that they might be experiencing headache. It's a side effect, it's expected. And therefore, you can give them Tylenol that will help, or acetaminophen that will help control that. Don't be in a hurry to take that as a priority when they start complaining of headache because it's a suspected side effect. So CAD is not the one that is going to kill you, but the complications that comes with CAD, that is what we are worried about. So let's talk about our first complication. When we have the narrowing um, of the coronary arteries, where less blood is going to the heart, but the heart muscles are not injured. In this case, we only have less amount of blood going in there. And one of the causes is that we have a narrowing, either through um, spasms or we have through the buildup of cholesterol, which is atherosclerosis. Whichever being the case, there's still blood going to the heart muscles, and so they are not going to die. And in this case, when it happens, our focus is going to be dilating the blood vessels. When we have a condition like that, it is referred to as angina. Please pay attention to it. So with angina, this is where the person is complaining of a chest pain resulting from ischemia, which is going to be narrowing of the coronary arteries. And it's because we don't have adequate amount of blood going to the myocardial cells. And therefore, the person will be complaining of chest pain. So the fancy word when you hear angina, think about chest pain. Now, this chest pain is not as a result of the distractions of the blood vessels, of the cardiac muscles, but there's less amount of oxygen that is going there. And so it's signaling the body that, hey, I still need more oxygen. And therefore, we call that angina. Remember, there's still blood going to the heart. It's just like the demand for the oxygen is less than what is being supplied, as the economist will tell you. So what causes that? Usually, when we have obstruction to the flow of blood, which is called atherosclerosis, and then on have coronary artery spasms. And this is where this time around it's not about the building of blood, but it's just like the coronary arteries are, um, we are contracting uncontrollably. So in this case, we want to stop this, and that's where the calcium channel blockers comes in. They can stop the spasms. Now, if it's atherosclerosis, we give them cholesterol lowering medications. And so these are some of the things, whatever is causing the problem, you try to fix it. If it is spasms and you give them cholesterol lowering medication, it's not going to work. So all conditions that increases myocardial oxygen consumption. So for example, when you have narrowing of the blood vessels and then you are exercising, it's likely that you can get the chest pain because your oxygen demand has gone up. Whatever you do that will increase any activities that will increase the demand of oxygen. So for example, when you're straining, this will increase the oxygen demand, and therefore it'll trigger the angina, which is the chest pain. So because we have different causes of this, I'm going to talk about the types of angina that we have. The first one that I'm going to talk about is a stable angina. This is where we say that this angina, the chest pain comes in because you are doing some kind of exercise or you are doing something that increase the demand of oxygen. For example, when you start mowing the lawns and then you start having a chest pain, the next time you are going to mow the lawn, you can start to take some kind of nitrate or nitroglycerin to open the airways, open the coronary arteries, and then you can safely move the lungs without getting the chest pain. In this case, we say that this type of angina is called a stable angina. So we can predict what is causing it, and then we can intervene before it happens. So that is stable angina. If it's not stable, then we're talking about unstable. At this point, this is what is causing is unpredictable. We don't know what is actually causing it. Usually, it can be a spasms, and in this case, even nitroglycerin will not be the one to even relieve the pain. Pain can be so severe that even when they are at rest, they can still get the pain. And so, what do? We have to find a cause and then figure out what is causing it. But in any way, there is a chest pain. Then we also have what we call the variant angina. Now, this is where we have vasospasms. In this case, this is where you need the calcium channel blockers. This is as a result of the arteries being undergoing spasms. And as a result of that, you start getting less amount of blood going to the heart, and then you get that chest pain. This can happen even at rest because it's not because there is an increase in oxygen demand. There is already oxygen going there. It's just like we have the spasms, and the spasm is what is causing it. In this case, you need more of the calcium channel blockers to be able to control such pain or to prevent that from happening. Sorry. But if in the question the person is having this type of angina or this sort of chest pain, nitroglycerin will not go to release that pain. Usually we give opioid to that patient, and therefore think about it. Opioid is the only one that can relieve the pain. Usually when somebody is having angina, we still have to get an EKG. The EKG will tell us the electrical activities of the heart. With this, we are more focusing on the SC segment. When the SC segment is elevated, we know that sometimes it has to do with the heart. And therefore, we see that the person is having angina. So when somebody is having an angina, the imaging or the test or what you should be thinking about is getting an EKG. It's one of the interventions that we put in place to help assess whether the cardiac is involved or not. So that's angina. So what do we expect to assess as a nurse? First, they'll be talking about the chest pain. Sometimes the chest pain develop very slowly. It can also be quickly, depending on how bad the spasms are. And then the pain is usually described as mild to moderate. It should tell you that this is more of angina because it's just like the more the oxygen is less, then the higher pain. So it starts slow and then it starts to increase. The pain is usually around, as described as substernal, and it's also be crushing, or sometimes they call it squeezing. And again, this pain may radiate to the shoulders, the arms, the jaw, the neck, and so anytime somebody complains of a pain, we don't just ask on the rate of 0 to 10 how bad is the pain, so ask to rule out any of these cardiac problems. And if one of the questions that we ask is that is the pain moving to any part of the body? If it's moving to the shoulders, to the arm, or to the jaw, or to the back, please talk about it. Think about cardiac. That is going to be helping you with your prioritization. It's more of a cardiac related. Next, the pain intensity. This is not the pain intensity is not affected by either inspiration or expiration. So your breathing pattern will never affect this pain, how bad the pain is. Take note of this. We have some conditions when they're having the chest pain, and if they breathe, the pain gets worse than compared to when they're breathing out. So that is why this information is very important. But in the case of angina, uh, this person, when they are breathing in or out, it's the intensity, how bad the pain is being, it's not being affected. The pain usually lasts sometimes about 5 minutes. However, it can take all the way to 15 to 30 minutes. Now, this pain is not going to be released by nitroglycerin or rest. If that does, then we say that that is a stable angina. But usually, we use morphine sulfate. Morphine sulfate is an opioid. It will, uh, it's going to it's going to dilate the blood vessels and also control the pain. The rest is going to be either the assessment that we had in the CAD, like deep smear. Now you know that this time around we have low blood that is flowing, so the person will be pale. That's what called pallor. Will also be sweating, or they'll be having diaphoresis. This is excessive sweat. Palpitations, which is part of the CAD that we talk about, and then the heart rate increases, which is called tachycardia. The person will be having dizziness and syncope. We talked about that as well because we have less amount of oxygen going to the heart muscles now. And cardiac output is also going to be low. And when I think of cardiac output, this is the amount of blood that is pumped out when the ventricles contract. When that happens, we have less amount of blood going to the brain, and this can cause syncope. Then we have hypertension. This is where the blood pressure has gone up, and it can also cause GI disturbances as well. So, what are some of the interventions that we can put in place? First of all, we have to make sure that the arteries are not blocked. We need to prevent the atherosclerotic plaque. So we put them on low cholesterol diet. The next one we're going to do is the body weight. We need to make sure that they are not overweight. So we have to control their calories intake because the more you are overweight, the more your oxygen demand goes up. So this, and then let's come to medications. If it's angina, we think about nitroglycerin, nitrate compound. Example is a nitroglycerin, isosobide dinitrate. This is a long term that will prevent the angina from happening. We did talk about calcium channel blockers. The most common one that we use is the diltiazem and verapamil hydrochloride. These are the ones that help dilate the blood vessels. We're talking about thrombolytics. Thrombolytic, these are the ones that break down clot. So anytime we hear thrombo, is the formation of clot, and then lytic means the breaking down of the clot. The most common medication that we use is TPA, or those of you who are working in a hospital, when your IV line or when your PIC line or central line gets clogged, what do we use? We request for a cut flow. It goes in and then break the PIC. Then we also have analgesics, which is pain medications. In this case, we give morphine, which is going to be, or you see morphine sulfate. The other ones that you might see is Dilaudid. This is hydromorphine. This is the medication of choice. It's an opioid when it comes to chest pain. The medical interventions. One of the things that the doctor can do is that they can go in and also open the coronary arteries. One of the things is that they will put a stent in there, and this stent will help dilate or open the blood, the coronary arteries, and there will be an increased flow of blood this time around. Then, another thing the doctor is going to do is coronary artery bypass. In this case, it's a surgery where the disease portion is going to be left there, and then they will reroute another um, artery to supply that area that is lacking the oxygen. So, in a nutshell, when the question talk about angina, it's a cardiac problem. In this cardiac problem, there is no complete blockade of oxygen going to the heart muscles. It's just like there's a narrowing, but less blood is going to the heart muscles, and as a result of that, we are not able to get meet the oxygen demand, and the person start complaining of a chest pain. That's all angina is all about. Our interventions, anything that will help dilate the blood vessels, anything that will prevent the formation of the plaque, anything that will help the free flow of the blood. That's all that we talk about when it comes to angina. The labs, we don't have any specific lab you're going to collect when somebody have angina. The best thing you can do probably would be, we're not going to talk about ABGs. So probably ABGs, which will tell you ABGs is not going to be even the labs. So we are not going to be more on the cardiac specific labs. And when we comes to the next problem, which is called, um, sorry, the next problem is going to be myocardial infarction. So in its infraction, this time around, we've graduated from narrowing to complete blockage. And when that happens, this is what is going to happen. When there's a complete blockage, this time around the cells are going to die. And when myocardial cells die, that's what we call myocardial infarction. That's all. So we've graduated from the narrowing of the blood vessels, and this time around we've come all the way to the structures of the cardiac muscles. So when that happens, we say you're having myocardial infarction. In this case, the lab that you should be looking for is going to be troponin. Troponin will tell you if we have myocardial infarctions or not. So please pay attention to that. With angina, there's no labs. With myocardial infarction, the lab you should be focusing on is the troponin. If you also see creatinine kinase over there, as selector that apply, you can also add that to it because the creatinine kinase will also go up. Like I rightly said from the beginning, creatinine kinase is not the best indicator for MI, but anytime you have a breakdown of muscles, the creatinine kinase will go up. So since the heart is also a muscular organ, when they are injured, yes, creatinine kinase will go up, but it's not absolute. But when you see the um, the troponin, it's telling you that yes, we have. Sorry, it's telling you that yes, we have myocardial infarction. So, so let's come to myocardial infarction. So with myocardial infarction, this time around, it is not a narrowing, it is a blockage. And this makes the complete type of oxygen to the myocardial cells. If that usually this happens when you have a clot or when you have a fat that is blocking oxygen from reaching the myocardial cells. In this case, the cells are going to die, or the muscles, sorry, the myocardial muscles are going to die, which is called the infraction. And when that happens, troponin is going to be released. When it is selected or apply, you also expect the creatinine kinase to be increased as well. But whatever happens, our major problem is that um, myocardial infarction occurs when there is an abruptly or severely deprived of oxygen. Not all clients experiencing the same cardinal symptoms when it comes to MI. So our assessment usually pay attention. If it is a woman, they may experience atypical discomfort. So instead of getting the chest pain, we'll be talking about having shortness of breath. We'll also be having fatigue, and often they'll present with that when you even get the EKG for women, ST will not be elevated. So it is not always that the ST segment will be elevated, but usually, as long as the troponin levels goes up, we say that the person has MI. So this is so if the ST did not get elevated, we call it non-ST elevation, myocardial infarction. That is good. When you hear the word instantly, that's all we're talking about. And then the T wave will be inverted, but usually you'll be talking more about the ST segment. Another one is when it comes to the older clients. With them, they will be experiencing shortness of breath. The reason is that the heart is not able to pump and therefore they will not be getting enough oxygen So they'll be experiencing shortness of breath, and then they'll be having pulmonary edema. There's congestion in the lungs. And since we have less oxygen moving to the brain, then they'll be dizzy, and then they'll be having altered mental status as well. So this is where they can also be showing delirium and also dysrhythmias on the EKG. So when you see an elderly person being confused and being agitated, and by now you know what delirium is, and then also being altered, and the doctor asks you to get an EKG, don't be surprised. Sometimes they're trying to rule out myocardial problems. Now, with diabetic patients, for them, they might not show symptoms at all. The only time that we know that they have MI is when the troponin level comes and they high. Sometimes they'll be also complaining of dyspnea, difficulty breathing, and then they'll be having neuropathy, which is usually nerve cells uh, getting infected or being affected. That's there. So they'll be having nerve pain. That's neuropathy. So with diabetic patients, they might not show any symptoms at all. And then with older clients, they'll be confused, they'll be having shortness of breath, they'll be having pulmonary edema, and then they'll also be having delirium as well. With women, they'll be complaining of shortness of breath, fatigue, and also when you look at the ST segment, it will not be elevated, and so you'll be having anstomy. Other than that, apart from these conditions, when somebody's having a chest pain, when somebody's having myocardial infarction, they will be having this chest pain, those cardinal symptoms that we talk about for angina, they will have all of them as well. But what are the risk factors? The risk factors, again, that means what are some of the things that can cause this blockade? Again, this type of questions will be under the risk reductions because these are the ones that put the person at risk. In this case, the building up of cholesterol. So we have to watch our height. So health promotion, you tell them that they should eat low cholesterol medication. This will result in the CAD if we don't follow the diet. And so when we do this and prevent this, then this one can be prevented, which is coronary artery disease. So when you you ask the patient to have at least an annual visit so that they can get the labs and see the cholesterol level. So elevated levels, it's put the person at risk of getting CAD, and CAD is because we have a buildup of cholesterol out there. Smoking is one of the smoking narrows the blood vessels, especially the arteries. And if that happens, we have less oxygen going to the blood vessels. So anytime you see smoking, please think about narrowing of the blood vessels. And that's why in smoking, smoking can also cause hypertension. Then obesity, when you're obese, with obesity, you have to think about controlling the person's calories. So this, the bigger the person, then the more oxygen demand. And when that happens, it puts the person at risk of getting heart attack or myocardial infarction. Then let's talk about physical inactivities. You have to make sure that the person who is having a sedentary lifestyle, sitting in one place all the time, they will be having some kind of exercises at one point. So you notice that here in this country, we get out of the elevators, we go to our workplace, we get out of the elevators, we go straight to our cars, no time to exercise. Then if we have too much glucose in the blood or impaired glucose tolerance, this is also another one. So with that of diabetes, make sure that diabetic patients are controlling their blood sugars very well. And of course, stress is one of the things that we have to look at. So stress control is very, very important. So what are some of the diagnostic studies or when somebody is having MI or you suspect that the person is having MI? First, if you're working in the ED, you have to get EKG right away. The EKG, we are focusing on the ST segment to see if we have is mean elevated or not elevated. Usually when it get elevated, we say you have STEMI, which is ST elevation MI. Remember, what determines MI is a troponin. Then the troponin levels will draw blood, troponin levels will go up, usually within, and they will remain elevated for at least 7 to 10 days. Then the creatinine kinase, total creatinine kinase will also go up as well. Myoglobin will also go up because this is coming from the muscles and the heart is a muscular organ. Then after some few days, white blood cells will begin to go up. In this case, we say that the person had myocardial infarction. So we say an elevated white blood cells count appears on the second day following the myocardial infarction. And this can last all the way up to 1 week. So this is where I told you that in case of this situation, don't think about infection, think about MI. But when the temperature um, goes up, then the white blood cells goes up, then you start thinking more about infection. So this is what I talk about ST segment. This is what I'm talking about. So for the normal EKG, whenever which is a electrical representation of the cardiac cycle. So when we have the atrium contracting, that's why we have the P wave. And when the ventricles are contracting, that's why we have the QRS. And so when we talk about the ST segment, we're talking about this is QRS, and then we have the T, so we're talking about the ST. So instead of it to come all the way down here, it gets up here, and that's what we call ST elevation. We also have depression. So when the ST segment depresses, it goes all the way there. So let's look at this. What are the diagnostic tests following an acute episode? When somebody get the MI, what are some of the things that we talk about? The doctor will figure out, okay, one of the things that the doctor will order after this is going to be stress tolerance test. Or in this case, the person will have that's a stress test. That's the most common word that we use. So the person will be asked to come for a stress test. So in this case, you are looking for the electrocardiographic changes and ischemia to evaluate for myocardial therapy or identify clients who may need an invasive therapy. And one of the things that we do, or you might hear, is called the thallium scan. This assesses if there's any ischemia or there's any dead muscles or heart muscles there. The thallium scan will give that information. But most of the time, what you are going to hear is cardiac catheterization. This is where they will put a catheter into the person's coronary arteries, which will help determine if there is to the extent or the location of the obstruction. Usually, if it is a blood clot, then they will put in a TPA or they'll put in a thrombolytic there to go and break the clot and open the airways if it happens on time. But when the heart muscles get destroyed or they are injured, they will not come back again. So in this case, we say that the injury, there's no need for you to actually break the clot again because the heart muscles are already damaged. So when it comes to PCI, which is called the percutaneous pulmonary intervention, usually it is more time specific. When you get it at the right time, then they can go in and then break the clot, and then blood will begin to flow and it prevent the injury to the heart. So, what are some of the assessments apart from the older people that we did talk about and women and diabetic patient? For a typical person, usually they will complain of pain, and then this pain will be said that it is crushing and sternal, a substernal, like that of the angina. The pain will be radiating again, like the angina, to the jaw, to the brain, or this time to the left, because the heart is tilted more to the left. Now, pain may occur without cause, primarily early in the morning, and then the pain is unrelieved by nitroglycerin. The only thing that can relieve the pain is opioid. Then the pain may last longer than 30 minutes. Um, Another thing is the GI. Well, the GI is always there. When I talk about GI symptoms, we're talking about nausea and vomiting. The person will be having sweating, which is the symptom of diaphoresis, and then they'll be complaining of dyspnea. So those are the things that you should know when somebody is having a myocardial infarction. Think about the labs, think about the cardinal symptoms, because this is where you'll be using a lot in your prioritization. So if the person complains of chest pain, and then you ask them, is the pain moving to any part of the body? If they say yes, think about more about cardiac. But if they say that the pain is not moving to any part of the body, and they are just located in only the sternal region, think more about GI. It's all that you need to know. And so you know that you prioritize cardiac over GI. And that's why it's always important to pay attention to where the pain is located. The other symptoms that we'll be talking about is going to be distress and then feeling of fear or anxiety. You'll be having pallor. Pallor is pale, and then cyanosis is a bluish coloration, which is an indication that we have less oxygen going to that extremity. Then we also have coldness of the extremities as well because we have less amount of oxygen, oxygenated blood moving to those extremities. Anytime oxygen is also the blood is moving, they don't move only oxygen, they move nutrient, they also move the heat. So when blood is not flowing, especially the arterial blood is not flowing or is being obstructed or occluded, then that side will become more cold. And that is why when somebody dies and blood is not circulating, what happens? Within some few minutes, a person get cold. So let's look at the intervention. What are some of the things that we can do for a patient who is already having myocardial infarction? First, we have to control the pain because the more you are in pain, the more uh, the demand for oxygen is going up. So pain is going to be our priority. In this case, our major pain medication that we're going to use is going to be morphine. Then we have to prepare to give oxygen because this time around, the heart is not so strong that we can be having the physiological process of getting the oxygen is going to be altered. So since the person is having dyspnea, difficulty breathing, we need to make the oxygen more available for the patient to get instead of just trying to get it from the air. Now, again, you have to want to put the person on the cardiac monitor so that you can monitor the electrical activities of the heart and see if we have any changes or not. You also be getting an EKG as well to see if there's elevation to the ST segment or there is a depression to the ST. Oh, there was no elevation to the ST segment. You assess the respiratory rate, the breath sounds, and to determine if there's a sign of any heart failure. And when there's a heart failure, usually we'll have pulmonary congestions. We'll talk a lot about heart failure later, but then when there's a heart failure, and usually it's on the left side, the person will be building fluid on that area, and then they'll be having shortness of breath. This may be an indication of, so when there's fluid buildup in the left side, usually when you listen to the breath sounds, you hear crackles. You might also hear wheezes, and then you can also have dependent edema. These are classic symptoms of a heart failure. Now, I did mention that with a heart failure, the lab that you have to think about is the BNP. Don't forget that. Ensure that bed rest is also again bed rest because we don't want to do them to do anything that will increase the oxygen demand. So bed rest, and then you place the client in a semi-fowler position to enhance comfort and tissues oxygenation. Please always stay with your client at all time when they are having this episode. So let's come to our treatment options. One of the things that we have to look for because we have problem with oxygenation, we give them oxygen. We start with our list medications, which is nitroglycerin. If it is the airway, it is the blood vessels that are narrowed, we can open them. We can also give them beta blockers. We have to give them morphine for the pain. And if it is a clot, we have to what? Break that clot. And usually we use the cardiac catheterization to go in to break the clot. You did mention about PCI, which I said percutaneous coronary intervention. It's usually we are saying that anything that will help diffuse the cardiac muscles. We have to do that. So if we have to go to the cath lab and then look at, place a stent in there, it's part of the coronary, the big part or the PCI that we're talking about. So in this case, we place a stent and then it will help increase the flow of oxygen. That's what we call percutaneous coronary intervention, PCI. Another thing that the doctor can do is called the coronary artery bypass, which is where the disease passes, the portion is going to be bypassed, and then educating the clients to lower modify their to lower modifying factors. So we talk of the modifying factors, smoking, they ask them to stop the smoking. Think about blood pressure, we have to control the blood pressure. And then you think about cholesterol food, you lower them. These are all life modifying factors that you can change. Next, I'm going to talk about heart failure. When we talk about heart failure, we're talking about the pumping ability of the heart has now come down, and therefore we are not able to meet the amount of we're not able to meet the demand of oxygen that is flowing to all parts of the body. So with a heart failure, this is where it can be a pumping problem. So heart failure is the inability of the heart to maintain adequate cardiac output, which means that the heart is not pumping the way it's supposed to be. In this case, the amount of blood that is getting out is very low, and therefore we have problems. The diminished cardiac output results in inadequate peripheral perfusion, so which means that we will not get enough oxygen to the extremities, especially to our hands and legs. Congestions in the lungs and peripheral may occur. So when you have congestions in your lungs, especially when you have a heart failure and blood is not flowing, those blood that is coming back to the heart after oxygenation, which is going to be uh, the left side, there'll be congestion in there. And then we also have problems with the peripheral, where when blood is returning to the heart, they are not able to, and so the person will be having edema. So the person can develop pulmonary edema or pulmonary congestion when the heart is failing. So the blood is not moving the way it's supposed to move. When that happens, the patient will be coughing out blood. It will also be dyspneic. It will also be having, they will be tachypneic. And then the going to be, we see that the person's heart is failing. Now, let's come to the types of heart failure. We have right-sided heart failure. When we talk of right-sided heart failure, this is where we're talking about the ventricles. So we talk about heart failure, think more about ventricular problems. That's where we're talking about. So either left or right, we have oxygenated problems. So let's focus more on the right heart failure. This means that the right section of the heart is not pumping blood. So when the right section of the heart is pumping, it pumps blood to go to where? To the lungs for oxygenation. So when that fails to pump, all the blood that is coming from all other parts of the body has no space to come in. And so wherever this blood is coming, they stay where they are. And so if they are coming from the legs, they have to stay in the legs, and that is where you have the edema. If they are coming from the brain, they have to stay in there. And so usually you see that the person will have jugular vein distension because those are the veins. So we have venous problems. Then on the right side, those are venous problems because the veins are the ones that are returning the blood to the heart. So it becomes a venous problem. So you have jugular vein distension. Then again, the extremities which are supposed to return blood to the heart, they cannot. Then when it comes to the liver also after it processes the blood, it has to go back to the heart for oxygenation. Again, they go to the right side of the heart, and so if the right side of the heart is not pumping, then the blood that's coming from the liver will stay where they are, and so the liver will be inflamed, and therefore you get hepatomegaly. With a hepatomegaly, how do we know if that is happening? You have to do a liver function test. Again, the liver function test, we are looking for bilirubin, we're looking for ALT, we're looking for AST, We are also looking for the um, albumin levels. If it is the kidneys, again, the kidneys is the one that detoxify or that cleanses the blood. So if the kidneys is returning blood to the heart for it to be for oxygenation, and then the right side of the heart is also failed, then the fluid is or whatever it is will stay in the kidneys, and the kidneys are going to be swollen. How do we know if the kidneys are affected? Then we have to draw what they call creatinine levels and also BUN. So anytime you talk about right-sided heart failure, what you should be thinking about is very simple. You are thinking about edema, and in this edema, it is not happening in the lungs. It is happening to any part of the body that is returning blood to the right side of the heart for oxygenation. So it's going to be mostly related to the venous problems. Pulmonary edema is not treated. So when that happens, we have pulmonary edema is not treated, death will occur from suffocation because of of the client literally who is drawing in their own fluid. So that is what happens. So in this case, we have problems. Now, signs of left ventricular heart problem. So when we have come to the left ventricles, this time around, the left ventricles is the one that pumps blood. And when it pumps blood, it goes to all parts of the body. If it fails to pump, then what is going to happen is that the blood, the oxygenated blood that is coming from the lungs, can no more cannot pump. And so what happens? The blood will be staying in the lungs, and that is what we call pulmonary congestion. Now, when that happens, you're having respiratory problems instead of uh, being systemic problem. So that's why I'm saying that signs of left ventricular failure are evident in pulmonary system. Okay, the pulmonary, which is the lungs. But signs of right-sided heart failure is more of systemic circulation. So signs of right ventricular problems is evident in the system, but in the left, it is the pulmonary. Do not forget this. It's very, very important. So what are the clinical manifestations on the right side of the heart failure? So let's talk about this. Again, we talk about edema, which is legs are edema in the legs and the sacrum, jugular vein distension. So you can see that everything is swollen apart from the lungs where we have a build-up there. Then abdominal distension. So again, fluid that is coming from the abdomen going to the heart will have to stay where they are. Hepatomegaly. The spleen will also be inflamed, and that's what we call splenomegaly. There'll be a weight gain because the fluid is staying in the person, it's not flowing at all. Anorexia and nausea. They can't eat anymore. They'll be nauseated, which is GI. Nocturnal diuresis. When we talk about diuresis, this is where the person will be waking in the middle of the night to be peeing a lot. And there will be swelling of the fingers and the hands, which is usually our first thing that we see when somebody had a heart failure or when somebody's heart is failing. Because of the liver problems, we end up getting what we call ascites. And I think I showed you a video of what ascites is. Then we also have increased blood pressure. So, and then even if it is left or right, there is going to be either an increase in blood pressure, normally when it's which is from fluid volume excess. So in this case, when somebody get a heart failure, their blood pressure can drop and the blood pressure can also go up. Now let me explain this. When it is volume where the fluid is not moving and then they just got into stuck in the vein, then the blood pressure in the vein will go up. On the other hand, if the heart is failing to pump, if it's a pumping problem, which will determine the pressure, if that is what is happening, then what is going to happen is that the blood pressure is going to drop. So when there's a pump failure, blood pressure drops. When there is a fluid excess, blood pressure increases. That is why, in terms of blood pressure, the in terms of blood pressure, it can go up or down, both the left side or right sided heart failure. So the laboratory findings that you have to be thinking about when it is right-sided heart failure is going to be the liver function test and then also the BUN or creatinine for renal. Now, with a left-sided heart failure, these signs are more of the respiratory symptoms. This is where there is pulmonary congestion and therefore the person will be dyspneic. We have tachypnea, increased respiratory rate. Then we will be having crackles in the lungs, and then the person will be having dry, hacking cough. And sometimes we have what we call proximal nocturnal dyspnea. So they will be having difficulty sleeping at night, or they will have difficulty breathing at night, and this will be waking them up at all times. So think about it. Anytime you have respiratory symptoms, think about the left-sided heart failure. Then the right-sided heart failure is going to be uh, the the systemic problems. What labs are we going to draw when the person is having left-sided heart failure? Of course, it's going to be our ABGs. So the ABGs will tell if we have hypoxemia. And the other one, the imaging, will look at the X-ray. And the X-ray can also tell us if we have buildup of fluids in the person's lungs. Then we have pleural effusion as well. And then we'll have the BNP. The BNP, I already talked about it. So when it comes to heart failure, think about BNP. When it comes to MI, think about troponin. Let's look at medications that will help, especially if it is a heart failure where the person is building fluid in the extremities. We use furosemide, and then can also use the bumetanide as well. These are all diuretics. They will help the person pee out all the fluid. Then if it is a pumping problem, we'll give digoxin. Digoxin, I made mention that you have to make sure that you get the person's blood, oh sorry, you get the person's heart rate 1 full minute before you give it. If it's less than 60, notify the provider before you make even attempt to give it. Beta blockers, metoprolol is going to reduce the heart rate or control the heart rate. Labetalol, and then also we have lisinopril to control the blood pressure, and then anticoagulant. Remember, anytime blood is not moving the way it's supposed to move, the tendency that we have a blood clot is very high, and therefore the person will be placed on anticoagulant to reduce chances of clot formation. Nursing and collaborative management. You always want to give oxygen to this patient. And in terms of health promotion, you give them diet that is low or that is um, low in sodium. And then you also have to restrict fluids and avoid alcohol, or you also have to lower the cholesterol levels that the patient takes. With acute pulmonary edema, this is another topic that will also be treated. But let me go through that since I've already treated the pulmonary congestion. So when you hear pulmonary edema, this is where we have the pulmonary system being swollen, and it's because there's a fluid buildup there. So in this case, the person will be having severe dyspnea. We talk about tachypnea, and then the nasal flaring. Usually, the use of accessory muscles. When it comes to children, you might be hearing retractions. These are all signs that we have cardiac problems. Then we have wheezings and crackles on auscultation. Anytime you hear crackles, it's a sign that we have fluid building up there. Then the person will now be coughing blood. When they cough, there's a large amount of blood that comes, and sometimes they will not be coughing blood. The sputum will be more frothy. Then acute anxiety or apprehension is also another thing that you'll be seeing because the person will be more anxious because they are lacking oxygen. So it's like they are drowning. You'll also be sweating. So when you hear profuse sweating, which is the same thing as profuse sweating is the same thing as diaphoresis. Again, their extremities will be cold and clammy, and then you'll be having cyanosis. What are some of the things that you can do to help this patient? First, if it is oxygenation, put them in a high follow position before you give them the oxygen. Make sure that there's an IV access where we will be giving the person furosemide or diuretics, and prepare for the administration of diuretics or morphine sulfate. Very, very important for the pain. And then also insert a Foley catheter so that you know how much fluid is coming out, because we want to see if the diuretics is working or not. You prepare for intubation or ventilation support if that the dyspnea become very, very bad. So those are the things that I want you to remember when it comes to the heart problems. The next one I'm going to talk about later is going to be the inflammatory disease of the heart, where I'll be talking more about endocarditis, myocarditis, and also what we have endo, which is the innermost part. So endocarditis, myocarditis, and um, I think we'll talk about that later. Thank you.